Welcome to today's webinar, Update on Emergency Contraception, Frequently Asked Questions about EC, Part 3 of ARHP's three-part webinar series on emergency contraception. I'm Melissa Werner, Director of Education at ARHP, and it's my pleasure to serve as moderator today. Before we get started on our content, I have a few announcements to make. To receive continuing education credit for this activity, you must take the pre- and post-tests. If you have not taken the pre-test and you are viewing this webinar live, you will find the pre-test link in your reminder email. The post-test link will be sent to you after the webinar. If you are viewing this webinar on demand, both the pre- and post-test links can be found below the video. In the webinar dashboard, you should see a chat box that you can use to enter questions throughout the webinar. Our faculty will answer as many questions as possible toward the end of the webinar. In about 4 weeks, you will receive an email from ARHP's Education Department with a link to a follow-up evaluation. We will ask that you complete this evaluation to let us know how you have incorporated what you have learned during the webinar into your work. Completing the pre- and post-test as well as this follow-up evaluation helps ARHP ensure we continue to meet your educational needs and interests. We thank you in advance for your time and feedback. Oops. Okay, so we would like to acknowledge that today's webinar was made possible through an independent educational grant from Efficacy. And why am I skipping ahead so many times here? I apologize. Can somebody please help me head back towards the Planning Committee disclosures? My apologies. Thank you. Okay, I appreciate that. On this slide, you'll see Planning Committee disclosures. As you can see, Dr. Aisha Mays is a Merck Nexplanon trainer and a trainer for Upstream USA. All other planners and faculty have nothing to disclose. In terms of our learning objectives, we are in all sorts of, this is quite interesting. Okay, at the conclusion of this program, participants will be able to, I apologize, I'm having so many technological difficulties here, describe some barriers to and facilitators of access to EC in the United States, discuss recommendations for breastfeeding women who need EC, advise patients on ongoing contraception after use of EC pills, and discuss potential drug interactions with EC pills. Okay, in terms of our wonderful presenters, I would like to introduce them today. We have Dr. Aisha Mays and Kelly Cleland. Oh no, I am so sorry, Kathleen Basink. Dr. Aisha Mays is a family physician and the Director of Adolescent and School-Based Health Services for Roots Community Health Center. She is also an adjunct clinical professor at the UC Berkeley UCSF Joint Medical Program and clinical researcher with the UCSF Bixby Center for Global and Reproductive Health, advancing new standards in reproductive health. Kathleen Basink is a professor of pharmacy at Chapman University in Irvine, California. Her clinical practice area is community pharmacy, and she specializes in women's health and public health issues. She's actively involved with several professional organizations, including ARHP, the California Pharmacists Association, the Los Angeles Safe Opioid Prescribing Task Force, the California Society of Health Systems Pharmacists, and the American Association of Colleges of Pharmacy. Without further ado, I'll turn the webinar over to Kathy.
Thank you for that introduction. It looks like our slides are advancing a little bit again. So a question that commonly arises, I know I hear it a lot from patients, is, will I have trouble getting emergency contraception when I need it? This can be based on the woman's experience with having to use emergency contraception in the past. It can be based on what they've heard from friends or colleagues. It can also come from things that they've read or seen in the media. Although the regulatory changes have improved access to emergency contraception in many ways, the real-world experience of actually getting emergency contraception is not always as straightforward as it should be. Next. So how many of your patients have told you that they've had trouble getting emergency contraception pills, either levonorgestrel or ulipristal acetate, at a pharmacy? And you can use your audience response pad to answer the poll. Should be about at the end of the polling at this point. So I'm not able to see the results of the poll. There we go. So it looks like the majority of you who are responding have only had a few women or patients tell you they've had trouble getting emergency contraception pills at the pharmacy. But some of you have had quite a few patients, up to 25 or more, having difficulty getting the levonorgestrel at the pharmacy. Next. So we'll talk first about access to levonorgestrel 1.5 milligram tablets. Although it is over the counter for all persons, regardless of age or gender, it can still be difficult for many individuals to access it. And I like to point out to patients who come into the pharmacy and who I talk to in clinic that although the package label directs women to take the pill within 72 hours after intercourse, studies and literature demonstrate that progestin-only emergency contraception may be effective up to 120 hours. And sometimes that difference between what they see and what they read confuses women when they actually go to take the product. Because levonorgestrel emergency contraception works by delaying ovulation, women should be advised to take the medication as soon as possible, since it's difficult for a woman to know when ovulation is about to happen, and the sooner it's taken, the more likely it will have been taken before ovulation has had a chance to occur. All one-dose levonorgestrel emergency contraception products are available readily and do not require a pregnancy test. Next. So in theory, we shouldn't have any confusion or any difficulty accessing levonorgestrel, but actually that's not always the case. The status of levonorgestrel has been over the counter completely since 2013, but the prior years of conflicting and complicated regulatory changes really have left us with a lot of confusion. One of the major issues that patients may run into when trying to purchase levonorgestrel emergency contraception in a store is misconceptions within the store about the regulatory status. In the current round of collection of data on emergency contraception access from the American Society for Emergency Contraception, 28% of participants were told that ID is required to purchase emergency contraception, even though we all know that's not the case. This misunderstanding about whether or not there are age restrictions is very common, and customers may even be turned away frequently because although the age restriction is no longer in place, confusion exists within the outlets and stores. Another problem with access to levonorgestrel is that a lot of stores don't stock it directly out on the shelf. It may be locked up, it might be in a plastic lockbox, and it may be that in order to actually get the product, a woman or a man has to go to the pharmacy counter itself. All of these barriers, be it a lockbox or not being available on the shelf, require the customer to go and talk to someone about their need for emergency contraception, which can be a barrier for many patients. Cost is also a significant barrier, and we'll address that in a few minutes. Next. So how can you increase access, and what are some solutions to access to levonorgestrel? One mechanism is to make sure that all personnel within the pharmacy are educated, as well as to reach out, if you're not within a pharmacy yourself, to the pharmacists in your local community and make sure that they know that you're going to be referring patients for emergency contraception and that it can be sold directly to anyone from the counter shelf out in the front of the pharmacy. You may also want to remind them that identification checks are not required, that there's no age or gender barrier in existence, and you may want to provide access, if they're not aware of it, to the Emergency Contraception Pharmacy Guide. It's a helpful resource for advocacy, and it's produced by the American Society for Emergency Contraception. Next. On this slide, you can see, along with the website for accessing the form, some visual images of what this information sheet looks like. It provides really easily understood information about the current regulatory status of emergency contraception, some basic information about how to use it, some the brands that are available, which can be important within the pharmacy, because if their wholesaler doesn't have one brand, they may have others. This can be printed out and taken, as I said, to the pharmacy, and they can keep it in the back where everyone can see it. Moving next to access to Ulipristal Acetate. Ulipristal Acetate is prescription only. Its label indicates it should be taken within 120 hours after intercourse. And it's been approved in the United States since 2010. And although it's been approved in the United States for quite a number of years, many pharmacies are unaware, as are many providers, of its existence, and it may not be as readily available from your local pharmacy. In a growing number of states, including California, where I'm from, Washington State and Oregon, pharmacists do have prescriptive authority to provide Ulipristal Acetate. So that's another option for improving access. Like levonorgestrel, it does work by disrupting ovulation and should be taken as soon as possible. Next. The fact that Ulipristal Acetate is currently prescription only does provide some increased barriers over levonorgestrel. In a 2015 study that showed that even among reproductive health specialists, only 52% of providers had ever heard of Ulipristal Acetate, and only 14% have prescribed it. Add to that the stocking of this product is very low in pharmacies, and we have a pretty significant access issue related to Ulipristal Acetate. Although only 10% of pharmacies in a survey were found to have Ulipristal in stock, 65% did indicate that they could order it. However, that meant a mean wait time of 24 hours. Given that emergency contraception is more effective the sooner it's taken, and that any delay can decrease effectiveness, I think we can do better. So you see, next, we have sort of a circular problem. Even 7 years after UPA was approved for sale in the United States, prescription use of this product is not widespread. If something isn't prescribed, pharmacies don't keep it in stock because they don't see the demand, and shelf space within the pharmacy is valuable. If it's not in stock, patients can't get the product in a timely manner, which is a big problem when you're dealing with a treatment such as emergency contraception, where time is of the essence. If women ask their healthcare provider in advance for emergency contraception, That can increase the awareness if the provider's not aware of it, and it can also increase utilization. So it's really important that we increase information and access to ulipristal acetate. Next slide. Some of the solutions, again, as with levonorgestrel, would be to call your local pharmacy and ask them if they can start stocking Ella. You can let them know that Ella is more effective than the over-the-counter levonorgestrel emergency contraception, especially for women who are of heavier weight, and we'll talk about that in a few slides. Make sure that you communicate with your pharmacist and let them know that as long as they will stock it, then you'll be able to send women to the pharmacy to get it. Next. Another thing you can do is to increase awareness among colleagues and patients about ulipristal acetate. You can say things like, are you aware that there is an emergency contraception product that's more effective than levonorgestrel? These discussions among colleagues can help to increase awareness of the availability of an option, especially for women who weigh more than 165 pounds, where there has been data, and it's been quite publicized, I think, that the effectiveness of levonorgestrel may be less in women who weigh more than 165 pounds. Next. You may be aware that Ulipristal is over-the-counter in Europe. Ulipristal does meet the U.S. standards for FDA standards for OTC status, and the company that makes the product is working on an OTC approval in the United States as well. It is a long process, and we don't know a lot of details about where things stand, but this may be an important step towards improving access to emergency contraception in general. Having another option for emergency contraception can also normalize emergency contraception as a contraceptive option. Hopefully, more competition in this market can also bring down the price of emergency contraception as well. Next slide. I mentioned cost was a barrier in some cases to access to emergency contraception. And for women and men who are paying out of pocket, emergency contraception can be quite expensive. Levonorgestrel at the pharmacy averages about $40 for the generic products and $50 for the branded product. Ulipristal costs more, and it does require a prescription, and if it's not covered by insurance, it may be $50 to $60. Next. Although the contraceptive coverage mandate under the Affordable Care Act should cover all methods of contraception without cost sharing, in practice I know that that's just not the case. The mandate does allow insurers to cover only one product per category, and sometimes that product is Ella and sometimes it's not. In most places, a prescription is required in order to get emergency contraception covered, even under the mandate. There are some states, such as Maryland, that are starting to require that insurance plans cover all OTC contraception, but this remains the exception, and implementation is a challenge. One way to help patients get emergency contraception covered, once you know what their insurance will pay for, is to offer an advanced prescription, even for levonorgestrel. You may also want to refer patients to an online resource. They should only be referred to trusted sources, and there are a couple listed on this slide, which would be selling the actual product, and there's not a concern about products that are substandard or counterfeit. Next. You can also think about setting up express emergency contraceptive visits in your clinic. This can help to facilitate access to emergency contraception. Remember that extensive screening, including pregnancy tests, are really not required for emergency contraception pills. The copper IUD is the most effective emergency contraceptive method for any woman. but it's not always acceptable or feasible in an express access situation. In situations where levonorgestrel is not, or sorry, where ulipristal acetate is not recommended when a patient needs emergency contraception because of missed pills, patches, or rings, or when the patient would like to start a hormonal product very soon, levonorgestrel can be recommended. Next. You want to include some very simple guidelines for all of your staff, including the front desk staff, on the basics of emergency contraception. You want to remind them that emergency contraception is safe and effective, it's easy to use, and it's also very time sensitive. So everyone within your clinic should be aware of how to access emergency contraception quickly using your expedited service or protocol. Next. Another question that frequently comes up has to do, it's quite a hot topic, is the effectiveness of emergency contraception in women who have a higher body weight, not just women who are overweight. Women who weigh 165 pounds or more may have a problem with efficacy, particularly of the levonorgestrel product. Next. This graphic shows what we know about weight and emergency contraception. In the purple bar, you can see ulipristal acetate, and in the bluer bar, you will see levonorgestrel. And you can see that as BMI increases, the efficacy of particularly levonorgestrel declines, and that the percent of pregnancies is increased. Next. Some of this difficulty with understanding the impact of weight and emergency contraception may stem from some regulatory decisions that were made over the last 3 years. Regulatory agencies have really struggled with this idea of weight and emergency contraception. In 2013, European regulators recommended a change to the labeling for Levo 1.5 milligram EC, indicating that it may be less effective for women who weigh more than 165 pounds and totally ineffective at over 176 pounds. However, after reviewing additional data, the European Medicine Agency determined that these data really weren't sufficient to warrant this warning, and in 2014 then ordered this language removed. In 2016, our own US FDA concluded its own review of the available data and determined that the data were too conflicting and too limited to reach a conclusion on this issue. The FDA has encouraged emergency contraception manufacturers to conduct further research on the issue of efficacy and weight. All of these regulatory decisions were made before the publication of a couple of articles that we're going to talk about next. So a 2016 study was convened to look at the pharmacokinetics of levonorgestrel-based emergency contraception. This study investigated serum concentrations in women of a normal BMI as compared to those with an obese category BMI. Now, while the study was small, being only 5 women enrolled in each group, the results proved to be significant. Women in the normal BMI group were given the standard dose of 1.5 milligram levonorgestrel, and women in the obese group were given first the 1.5 milligram dose, followed by a 3 milligram dose in another cycle. Next. And what they found was women who were obese, who took the lower dose, or the normal dose, I should say, of levonorgestrel of 1.5 milligram, had serum levels about 50% lower than the women who were of normal BMI. When those same women were given a 3 milligram dose of levonorgestrel, their blood levels were about the same as women who had a normal BMI. On this slide, you'll see the results of the first study that I talked about, along with the second study, which was a crossover study in which women who were obese were given a dose of levonorgestrel, as well as women of normal BMI, and then they were crossed over to ulipristal acetate. This second study did not double the dose. However, the levels that were obtained in the second study also supported the fact that women who were obese, given the 1.5 milligram dose of levonorgestrel, had about 50% lower blood levels than women who were not obese. There is certainly further research needed on this study, and the previous one, or in this area, but there is some suggestion that doubling the dose of levonorgestrel emergency contraception could be a reasonable approach for women who are in the obese BMI category. Again, more study is needed in order to make that conclusion definitively. Next. I think I've kind of covered this. So this research currently, as I said, supports the theory that weight definitely impacts emergency contraception efficacy. This impact is most significant with levonorgestrel. The suggestion that the dose can be doubled may not be feasible for all women. The efficacy of doubling the dose is unproven. Although we know the blood levels become the same, that doesn't necessarily mean that the blood level is directly correlated with efficacy. There has been a study showing that even a half dose of levonorgestrel, the 0.75 milligram, can still disrupt ovulation, and so there may be other factors at work besides serum concentration. So until more data is available, we won't really know whether doubling the dose in women who are in the obese category will solve the problem of efficacy difference. Next. So it looks like I have a slide that's not here. So I'm going to turn it over to Dr. Aisha Mays, who's going to talk about many common clinical questions that come up in using emergency contraception.
Thank you so much, Kathy. So now that we've talked a little bit about some of the pharmacokinetics and around emergency contraception, and we'll come back to some of that as well, I want to talk about some clinical questions that have come up in our previous webinars. And one of them is, can I use emergency contraception if I'm breastfeeding? So we know that this is a common question, and so let's talk about some of the clinical issues specific for women who are breastfeeding and would like to use emergency contraception. So before we start, let's take a poll. For you all in your practice, what percentage of your breastfeeding patients have you asked about emergency contraception? And you see your list of answers there. And so let's see what's come back from our poll around what people are seeing in their practice. So it looks like or a little bit over half of you have not had patients come in asking for emergency contraception and breastfeeding, but then somewhere between 25 and 50%, and then the other half of you have had patients who are coming in asking about emergency contraception who are breastfeeding. So we do know that this is relevant, and if you're not seeing it in your practice yet, it's good to have this information in case you have patients coming in requesting emergency contraception. Next slide. So breastfeeding women may have questions about emergency contraception and whether it's safe to use. Here are some guidelines. First, we just want to remind you that patients may not need emergency contraception if they're exclusively breastfeeding on demand. This does not include women who are pumping on a schedule. and if their baby is less than 6 months old and they have not had a period. Again, that's the lactation amenorrhea contraceptive method. I would just a caveat here that this is really should be used for adult women and not for those of you who may have adolescents in your practice who are pregnant or postpartum. For women who fit this criteria of the lactational amenorrhea method, that may actually provide adequate protection, and emergency contraception may not be needed. Next slide, please. So for patients who do not fit the criteria of lactation amenorrhea method, or those who are concerned and want to take EC anyway, we can let them know that there are no restrictions of the progestin-only emergency contraception pills by breastfeeding women. That means they are safe to use for women who are breastfeeding. Although the U.S. label for Ulipristal Acetate does not recommend that breastfeeding women use it, research has shown that it's suitable for breastfeeding women. Guidelines vary as to whether users should express and discard milk for 24 hours or 1 week. So there may be varying results around this. If a woman really wants to be on the more conservative end, she may want to pump and discard for up to 1 week. Next slide, please. So generally, we and so now let's think about the copper IUD again as our third method of emergency contraception. We know that copper IUDs and EC generally follow the same protocols for routine use. The copper IUD may be an excellent choice overall for breastfeeding women who need emergency contraception and who want to use ongoing contraception. Breastfeeding women should be counseled that the risk of uterine perforation is slightly higher among women who are not breastfeeding, but overall the absolute risk is still low. In one study, there were 3.7 perforations per 1,000 insertions among breastfeeding women, as compared with the overall risk of perforation, which is 1 in 1,000. So again, still very low. Next slide. And so another question that has come up in our previous 2 webinars is, if I use Ella, can I start my new birth control method right away? And so this is something that we do want to go in depth about, because we know when patients come in requesting emergency contraception, they often want to start an ongoing method, and we want to talk to them about that. So there may be confusion among your patients and colleagues about what to do after ongoing contraception, after any emergency contraceptive method. We'll talk about this in depth as well. Next slide. So first of all, to review, a 2015 study considered whether following ulipristal acetate was which is an anti-progestin, immediately with a progestin-containing contraceptive will counteract the effects of UPA. They found that in cycles where women started a placebo pill the day after taking UPA, there was only 1 ovulation cycle within 5 days. That's 3% in this particular study. When UPA was followed by desogestrel, which is a progestin-only contraceptive pill, ovulation occurred within 5 days in 45% of cycles. So we see there's a big difference there. So normally, if a woman comes into clinic after unprotected sex and takes UPA, we assume that she's using the most effective oral EC and that it will probably be successful in delaying ovulation. But if at the same time the woman then quick starts a desogestrel pill or progestin-only pill, there's a good chance that it will counteract the effects of the UPA, and that she might be right back where she started in terms of her pregnancy risk. Next slide. So the results are really quite compelling here, and it does appear that following UPA with a desogestrel-only pill, which is the progesterone-only pill, can compromise the efficacy of UPA. But we are left with some important outstanding questions that we really should discuss. So the first being, next, really, do these results apply to other pills? We don't have an equivalent pill in the United States to the pill that was in this study. So we can't be sure where the results apply to pills that are available here. This is important because of how desogestrel pills work. This pill formulation is much better at blocking ovulation than other progesterone-only pills. So perhaps the effect of UPA might be different if a different pill were used. The second question we should really think about is, does this apply to other hormonal contraceptives? If Mirena or the implant or Depo were studied in the same way, would we also find the efficacy of UPA to be compromised? The third question we should think about in terms of the timing of UPA, when UPA was taken, or should we think about that or the time since unprotected sex occurred? Since sperm are not viable until 5 days, perhaps we can change the recommendation to read 5 days since unprotected sex occurred. And then finally, given that we don't know the answers to these questions right now, how do we weigh competing risks? What's more important? The potential loss of efficacy of UPA if we quick start a hormonal method, or the potential loss of being able to start a method with a patient on that day. Next slide. And so we think about some questions that we want to ask in order to help us to figure out how we're going to address each clinical scenario. So when counseling patients who need emergency contraception and want to start a new method, we want to ask these questions first. Number one, is UPA EC even available? We discussed in some of the previous slides, it can be very difficult to access UPA for patients. And it's available by prescription only. It's also not consistently available at all pharmacies. So that's what we need to know first. Secondly, we want to ask about the patient's cycle day and the timing of sex, and consider whether the patient is at greater risk for pregnancy from the act of intercourse that just occurred or from future acts of intercourse. Number three, we want to find out if she's interested in an ongoing contraceptive method and whether she's likely to return for a follow-up visit in a few days, if she wants to have a provider-dependent method like a hormonal implant or an IUD. And third, and finally, we want to be sure to ask whether she needs EC because she missed her pills, a patch or ring, or whether she wasn't using a contraceptive method to begin with. So on the next slide, we'll show some basic guidelines based on these answers to give us more information on how we can, again, address these clinical scenarios. So this slide will talk about, again, when to advise, how to advise contraception after emergency contraception. These are just some basic takeaways. There are always multiple considerations to balance here, including which EC method is most likely going to be effective. We talked about the weight restrictions and how that can affect the efficacy of particular EC methods, the levonorgestrel methods. For patients taking UPA, we want to remind them not to start a new method within 5 days when they had unprotected sex. If they're going to start pills, patch, or ring, have them set a reminder to start their new method 5 days from when they had sex. So we do want to either give them the prescription or give them the new method on site, and then give them this recommendation to take it at home 5 days later from unprotected sex. Patients who feel strongly about starting a provider-dependent method like an implant or the hormonal IUD we know that this can be difficult or impossible for some patients to come back on another day. If that's the case, you may want to recommend that the patient take the levonorgestrel emergency contraception pills and provide the new method on that day. All of this information can also be found in the CDC Selected Practice Recommendation Guidelines on when to start contraception after UPA or levonorgestrel pills. Next slide.
Although there are very few drug interaction concerns when it comes to emergency contraception pills, your patients who have certain medical conditions may be concerned about whether emergency contraceptive pills are safe and effective for them to use. Next. The hepatic enzyme system, the CYP453A4 enzyme-inducing agents, can reduce the efficacy of ulipristal and levonorgestrel by inducing their metabolism. For patients who are taking medications to prevent seizures or using anti-seizure medications for other indications such as bipolar disorder, for women who are on HIV therapies, or taking some additional medications such as high doses of glucocorticoids, modafinil, which is Provigil, pioglitazone, rifabutin, rifampin, or St. John's wort, you may need to consider the potential for these medications to reduce the efficacy of emergency contraception. For these patients, the first-line option for emergency contraception would be the copper IUD, where there is no drug interaction with these medications. But in situations where the copper IUD is either unavailable or an approach that the woman does not wish to follow, a double dose of levonorgestrel of 3 milligrams can be recommended. Now, the efficacy of 3 milligrams of levonorgestrel is uncertain, but the safety is well documented. A double dose of ulipristal acetate has not been studied and cannot be recommended at this time.
So this question has also come up in our previous webinars, and that is, do EC pills cause an abortion? And we certainly want to discuss this because there could be tremendous confusion around what emergency contraception is and how emergency contraception works. And so let's take a poll and see what has happened in your practices. In the past year, how many patients have asked you about emergency contraception pills, how they work, and particularly whether EC causes an abortion? And let's see the results that have come back from our poll. So it looks like we may have lost our poll a little bit here. If we are able to get it back, we'll produce those results at the end. So next slide. So the mechanism of action is really important to understand with levonorgestrel EC and ulipristal EC, so that we can understand how it works. We know that levonorgestrel emergency contraception works to prevent by disrupting ovulation, and is only effective before the LH surge has begun. Once the LH surge is underway, the levonorgestrel EC is no longer able to affect an ovulation. Levonorgestrel EC doesn't have an effect on fertilization or implantation, and so we know that it doesn't have any effect once that has occurred. Therefore, you can reassure concerned patients the levonorgestrel EC does not have the potential to end an early pregnancy or even prevent implantation of a fertilized egg. Next slide. And so here's what we know about ulipristal acetate. The mechanism of action has not been studied as extensively. Some people speculate about whether UPA is able to work as an abortifacient because it is in the same general class of drugs as mifepristone, the abortion pill. New research has been published in the last several months that has helped us understand how UPA works as emergency contraception. One recent study, published in 2015, it was an in vitro study of human embryos in a uterine model. 10 embryos were exposed to UPA and 10 were not. The number of embryos that successfully attached in each group was not statistically different. This is obviously a small in vitro study, but may support the theory that UPA-EC does not have an effect on implantation. Next slide. And so just providing a little bit more information about UPA, another study published last summer investigated the question of whether the mechanism of UPA using a similar approach to the studies of levonorgestrel EC. In this study, ovulatory status was determined by menstrual history, ultrasound, and serum hormone profiles at the time of recruitment. Women seeking EC were classified into pre-ovulatory and post-ovulatory groups and given UPA. Among those who used UPA before ovulation, 77% of pregnancies were prevented. The pregnancy rate in this group was statistically lower than the number of pregnancies that would have been expected given cycle timing. Among women who use UPA after ovulation, only 36% of expected pregnancies were prevented. The pregnancy rate was no different than what would be expected without the use of EC. So this study really suggests that the primary mechanism of action of UPA-EC is interference with ovulation, and that it may have no effect on once fertilization has occurred. Next slide. So overall, our message for patients and for our colleagues really is the best evidence that we have suggests that EC pills work before ovulation and probably not after. If EC pills did work after fertilization by preventing or disrupting implantation, their efficacy rate would be higher. Medical consensus is that pregnancy begins once a fertilized egg has successfully implanted in the uterus. No EC methods have been shown to work after this point. So concerned patients can be reassured that EC does not work as an abortifacient. Next slide. And so this question also has come up in previous webinars. I know the copper IUD is an option for EC, but I'd rather use the Mirena. Can I use that for EC? So let's talk a little bit more about this. So here's what we know about the levonorgestrel IUD as EC. So overall, we know the copper IUD has been documented for over 40 years as being able to be used as EC, one of the most effective forms of emergency contraception. It's nearly 100% effective in preventing pregnancy as an emergency contraceptive method. One study shows that it's effective at any point in the cycle as long as pregnancy has been excluded, so use does not need to be restricted to 5 days after sex. But this EC method is not frequently used in the United States. There are many reasons for this, including access and awareness issues. Another barrier may be that some proportion of women are concerned about the bleeding profile of a copper IUD and would rather use the levonorgestrel IUD instead. But the levonorgestrel IUD as EC has not been extensively studied and is not yet recommended as an EC method. Next slide. So let's talk about some recent data specifically around the levonorgestrel IUD as EC. There is new research emerging. In one recent study, women seeking EC at a family planning clinic were offered 2 IUD options, one the copper IUD alone or a levonorgestrel EC pill along with a levonorgestrel IUD. The majority of women in the study preferred the levonorgestrel IUD. There were no pregnancies in either group attributed to method failure, but it's important to note that there was an ectopic pregnancy in the levonorgestrel EC and levonorgestrel IUD group. Gestational dating suggests that this pregnancy is due to one of several acts of intercourse that took place earlier in the cycle. Next slide. And then we are happy to share some new data from 2 ongoing studies in which the levonorgestrel IUD alone is compared to another established EC method. In the LIFE study at the University of Utah, the levonorgestrel IUD is compared to UPA-EC, and in the RAPID EC study from Washington University in St. Louis, they compared the levonorgestrel IUD and the copper IUD used as EC. What's new about these studies is that there is no EC pill given in conjunction with the levonorgestrel IUD. The levonorgestrel IUD is given alone as an EC method. Enrollment is underway in both studies, but so far there have been no pregnancies in either one. So that's pretty reassuring. So again, more around the levonorgestrel IUD as EC. Again, these are small studies. More data is on the way. Given that the pregnancy rate is a rare outcome in this type of study, some feel like this is not adequate support for offering the levonorgestrel IUD as EC. Again, more research is underway. Many women would rather get a levonorgestrel IUD because they prefer the bleeding profile. So if this were an option for EC, it could improve uptake of highly effective contraception among EC users. But the ectopic pregnancy in the study raises an interesting question. Should we exclude women who report acts of unprotected intercourse more than 5 days prior to IUD insertion? So given this data, we're ready to recommend this approach. Are we ready to recommend this approach? Although there are no treatment failures in this study, some providers may not be ready to recommend concurrent insertion of levonorgestrel IUD at the time of EC until more data are available. Next slide. So we're going to try our poll one more time. So really, given what we know, what's known about the providing levonorgestrel IUD alone as EC, would you be comfortable offering this option to patients? Okay, and let's see what's come back from our poll. So it looks like our poll still might not be working. If we're able to get that up before the end of the webinar, we will publish those results. Next slide. And so that takes us to the end of our webinar today. We have some references here from all the information that we presented in the slides. And some additional references on our website. Additional bedsider.org has really great information about contraception, all up to date. The American Society for EC, emergency contraception, also nottolate.com, great information around emergency contraception. And so I'm going to take this back to Melissa, and she will wrap us up.
Donnie, actually, are you able to read out the questions for our panelists, please?
Yes. So right now we have our box open, and so questions are available right now for the next 5 minutes or so for you guys to go ahead and send any questions that you may have so that we can read them out loud and have our panelists answer them for us. We're going to give you guys about a minute or so.
Donnie, have any additional questions come in?
No.
Okay, well, let's go ahead and wrap up then. I would like to thank Kathy and Aisha one more time for that excellent presentation. And I'd like to remind participants to take note of the following. As a reminder, please be on the lookout for an email from ARHP's Education Department with a link to the post-test survey. Your CME or CE certificate will be generated at the end of the survey. Please be sure to print the certificate before closing the internet browser. If you have questions, you're welcome to email us at education@arhp.org. Also, you can access recordings of the first 2 webinars in this series and many other resources on EC and other topics at arhp.org. I would like to thank you for taking the time to participate in this webinar, and we certainly hope you will take part in other ARHP-sponsored educational activities again in the near future. Thanks again. Take care.